Welcome to CFRI's Cystic Fibrosis Community Voices, a video podcast series created by and for the cystic fibrosis community.
I'm very honored to be here tonight with Dr. Rick Moss. He's Professor Emeritus of Pediatrics at Stanford University, former Chief of the Pediatric Pulmonary and Allergy Divisions, and Director of the Stanford Cystic Fibrosis Center from 1991 to 2009, a Principal Investigator for the Cystic Fibrosis Foundation's Therapeutics Development Network, and so much more. Such an accomplished person, and I apologize for abbreviating your biography. But very honored that you're here, and I'm also thrilled to be here with Becca Roanhaus, who will be introducing herself and sharing her story very shortly. So a key motivator for this town hall was a desire to further the discussion that we started almost exactly a year ago at an externally led patient-focused drug development meeting on CF that we held in Maryland, and it was coordinated in part with representatives from the Food and Drug Administration, the FDA. And the meeting was live streamed. People could call in, people could email in, people could attend in person, and it brought the incredibly diverse needs and issues faced by the CF community to the forefront, most especially for representatives of the FDA, so that they felt a sense of urgency and it enhanced their understanding of how complex CF is. And I have to say, I'm really thrilled that this week, and who knows, this will be a podcast, so people may be watching this later, but it was this week that the FDA did approve Vertex's new triple combination CFTR modulator therapy. This was already a fast-tracked drug. They were expecting to have a decision by March, and instead it happened within approximately 3 months, unbelievably quickly. And what we were told was that the input from that externally led patient-focused drug development meeting had a huge impact on really expressing the urgency for new therapies for our community. So it was an important day, and we don't want it to end because, as we know, people's issues and needs are continually evolving. But during that day, we had ranking of what the issues were that people faced. And last month, we talked about GI issues because it was pretty interesting that GI issues and respiratory issues really were neck and neck in terms of the impacts on day-to-day living for those with CF. But today, we do want to talk about specifically respiratory issues and what that means. And it may be everything as challenging as exacerbations, hemoptysis, pneumothorax, but also issues like chronic cough, which for many people is an issue. So we will get to that. We want to hear everybody's own experiences around those. But before we do that, I am going to turn it over to Dr. Moss to just give us a wonderful overview of the key respiratory issues.
Thank you, Siri, and thanks to the staff, CFRI, for inviting me to participate in this event. And welcome to all of you who are tuning in. So I was asked to talk about respiratory complications, and the first place I went was the registry. Most of patients in the States are in the CF Foundation's registry, close to 30,000 patients now. So it's really become one of the most remarkable places to get information, and that helps guide new treatments, planning, selecting patients, learning what other drugs are being given for interactions, many different things. The CF Foundation's patient registry, can you see the first slide up there? Lists 4 different major respiratory complications, and I'll talk about a few more things in that, but I decided to start with this. And you can see there that about 5% of all CF patients are listed as having ABPA, or allergic bronchopulmonary aspergillosis. The first thing to note is that appears there because somebody at that center gave that label to that patient. And whether or not that's an accurate label or not is up to that center. And so the data is only as good as the people at the centers putting in the data. Over the years, the data has become pretty solid. So I think it's a pretty accurate rendition. We think overall, if you look at single centers, that maybe upwards of 10% of patients may have ABPA. So it's quite a common complication. I'll speak a little bit about it later. The second thing you see there is asthma, and about 1 out of 3 CF patients also carries a diagnosis of asthma. Not too surprising, about 10% of the general population has asthma. So it's about 3 times higher in CF than in the general population. And diagnosing asthma in CF is rather difficult because a lot of the symptoms are the same, a lot of the tests look very similar, and it's somewhat controversial as to how solid a definition can be used to treat it. But basically, the proof is in the pudding in the sense that people who get diagnosed with asthma tend to be put on inhaled steroids, and we know, again, from the registry that 40 to 50% of CF patients in this country are on steroids, inhaled corticosteroids. The major complications that we worry about as providers in terms of serious or life-threatening issues are shown there as hemoptysis and pneumothorax. Hemoptysis is, of course, coughing up blood, and you can see that the registry divides pediatric from adult patients, and it's much more common because it is one of those things that is more likely as the disease progresses. And hemoptysis is divided into non-life-threatening and life-threatening domains by how much or how frequently or how chronically the blood is occurring. And you can see that massive hemoptysis is much rarer. So most cases of coughing up blood are not life-threatening and can be treated by very conservative measures. But there is a small fraction of patients for whom it can be life-threatening, and that's where things like bronchial embolization and sometimes use of procoagulant drugs can be helpful. The last thing that's listed there is pneumothorax, which is sort of like blowing a hole in a tire, where air is escaping from the lung through a leak into the space around the lung. And in CF, this actually, in many cases, is less dangerous than people that don't have CF because the stiff lungs associated with CF lung disease actually help prevent the lung from totally collapsing. But in some cases, it can be extremely dangerous, and in almost all cases, it's associated with a lot of pain, so it does often need to be treated. Moving off the complications as listed in the registry, I think this kind of discussion would be remiss if we didn't talk a little bit about infection. And this is the data over the last 15 years or so, or longer actually, 25 years, to look at the prevalence of different major bacterial pathogens in CF. And you can see there that over the course of these years, there's been a steady increase in Staph aureus, both the sort of regular staph and also the methicillin-resistant or MRSA type staph, which is shown there in that orange line. So that now about over 20% of CF patients have some form of methicillin-resistant staph, still very treatable with other drugs, but it does lead to more concern about transmission. There's now some evidence that MRSA is associated with more rapid decline, so people have generally become more aggressive about treating that. The flip side of that, which is a good story, if you look at the blue line of Pseudomonas, we've gone down from about 60 to about 45 or 44% over this period of time. And I think a lot of that reflects the increasing use of eradication regimes of antibiotics in children with CF, but also sometimes in adults, so that whenever this bug appears, we try to swat it with a course of antibiotics. In some people, that works. In others, it doesn't. It works about 80% of the time, the first time. But eventually, many people do become chronically infected. And when we get into that chronic phase, then we switch over to what's called a suppressive antibiotic regime, which often involves inhaling antibiotics every other month, or in many patients nowadays, continuously alternating different antibiotics. There are some other things that I think are worth mentioning. In particular, the last line there, you see non-tuberculous mycobacteria, which is now reported in about 13% of CF patients. And as you see there, it tends to occur somewhat later in young adulthood with a median age of onset of about 21 years. And the reason we pay close attention to this one, there's really two reasons. One is it's rather difficult to differentiate simple colonization of the respiratory tract from actual lung disease due to this bacteria. And more important, it's very difficult to treat, so that no matter what kind of non-tuberculous mycobacteria infection a patient may have, it usually requires several different antibiotics for a long period of time to clear it, and sometimes it really can't be cleared. So this is something that is tracked very carefully. We do know of cases of cross-transmission. So again, this supports the idea of being very vigilant about our infection control practices. Something that maybe you don't think about in terms of a respiratory complication, but I think is very important, is to continue to focus on things that we can prevent. And foremost among these is exposure to pollutants like tobacco smoke. And one of the things the registry does collect is data on secondhand smoke exposure as well as active smoking. To me, it's sort of shocking to see that we actually see quite a bit, not only of active smoking, especially in the teen and young adult years, about 4 or 5% you see there in that orange bar, but much more commonly exposure to others in the home or work environment who are smoking. And this is something that's obviously completely preventable. And clearly, exposure is not good for you, so it's something to consider in terms of preventing the acceleration of lung disease. And this is a completely preventable respiratory complication, somewhat like getting the flu, so getting your flu shots contributes to controlling that somewhat preventable complication also. Some things we can't prevent in CF, even today, even with the modulators. Whether this goes away with new modulators over time as we treat very young patients for years and years, we don't know yet. But what we do know is that the occurrence of bronchiectasis really is what drives most of the problems in CF. And this is a picture of a postmortem lung segment of an adult who passed away from CF. And you can see there quite obviously that there's blood in the lungs, it's filling the airway, and these yellow areas are basically pus-filled pockets in the lung also. So the lung is gradually, in fact, destroyed over time by this chronic inflammation and infection process that is part and parcel of CF. I don't really think of it as a complication. To me, this is CF. And it begins, we know now from studies even in babies, in many patients before the first birthday. So it's something we need to get on right away after diagnosis. This lists the primary cardiopulmonary complications beyond those I mentioned. Exacerbations, again, is a big topic. I think of it as part and parcel of CF. About 30 to 40% of these exacerbations are probably related to viral infections, common colds or flu or RSV. Some may be due to new bacteria or fungi, and these things need to be treated obviously very aggressively. And I think one of the main issues about getting on top of CF is recognizing exacerbations in young and healthy patients and being aggressive. Studies have shown that kids tend to be treated less aggressively than adults, which may not be the best thing to do, even though we're trying to be nice to the family and not have them need an IV or come into the hospital, but this may not be the wisest thing over the long term. Atelectasis is collapse of a portion of the lung from a big mucus plug, and sometimes that is something that requires not just airway clearance, but bronchoscopy to try and suck that mucus plug out. More recently, people have really focused more and more on overall health and the contribution of sleep-disordered breathing, like obstructive sleep apnea in patients with CF. And this is something that has tended to be ignored unless it's very obvious, but can affect overall lung health over time. Two things that are less common today are nocturnal hypoxemia, which means low oxygen while sleeping. That's sort of related to obstructive sleep apnea or just impaired lung function. And something I used to see a long time ago called cor pulmonale, which is basically a strain on the right side of the heart from disease in the lungs. Luckily, this is much less common today than it was 20 or 30 years ago. So progressive pulmonary damage and these complications of pneumothorax and massive hemoptysis, which has a definition you see there of at least 240 milliliters of blood in 24 hours or requiring transfusion. Some people use a little bit more lax standards to sort of decide when to be more aggressive than using conservative treatment, which usually just means withholding airway clearance and nebulized meds for a day. I mentioned that I talk a little bit more about ABPA, not to say too much, but we think it occurs in about 10% of CF patients. Even though the registry says 5%, it's probably underdiagnosed or underreported still these days. And it is associated with asthma-type symptoms, including wheezing, coughing up of mucus plugs that sometimes can be rust-colored, some chest pain or tightness, and often an exacerbation. We found that about 10 to 15% of exacerbations were either associated with or caused by ABPA episodes. So it's something to keep in mind with a change in lung status. And the diagnosis really depends on a combination of blood tests, imaging, and clinical findings. Sinusitis, if you consider it as part of the respiratory tract, which I do, is pretty much universal in CF. And people that have a lot of symptoms obviously do benefit from referral to ear, nose, and throat people who can do sinus surgery, take out polyps, as well as clear out mucus that's impacting in the sinuses and causing unpleasant symptoms, including loss of smell, which has a lot to do with taste and appetite. And maybe you can talk about that, Becca. So it's a pretty common issue that people have to deal with. And I mentioned previously this right heart failure situation, which luckily has become much less common as CF in general has become more tractable to the various treatments we have for the lung disease. And finally, of course, lung transplants, which even today we still use that FEV1 cutoff of 30% as one important, although not the only, indication to have an evaluation done for a possible transplant. So I mentioned hemoptysis. It's as I mentioned before, it becomes more common as patients get older. And what it really is about is the fact that the blood vessels that supply the lung tend to run along with the airways anatomically. So if the airway gets very inflamed with infection, it can erode into a blood vessel that's running along beside it, and that bleeding will go into the airway, and the patient will experience that and cough up blood. A very frightening situation for everyone. But again, we need to keep in mind that the vast majority of these episodes are not life-threatening and resolved by themselves with conservative treatment. But there are cases that need embolization, which involves interventional radiologists going into an artery and injecting usually some little foam-like particles that will block off the bleeding blood vessel, which requires a lot of expertise and is not without some element of danger. Pneumothorax, used to see this a lot in children, almost never these days, because CF lung disease has come under semi-control in kids in recent years, but certainly still occurs, and again is related to age and general progression of lung disease. And in general, once you have it, you are at enhanced risk to have another episode. And the treatment really depends on how bad it is. Oftentimes just watching, sometimes just giving some extra oxygen can help resolve it. But sometimes you also need to have a surgical intervention with a chest tube put in to drain that air out. And if that doesn't go away spontaneously, sometimes some chemical needs to be put in, kind of like rubber cement, to glue that lung back on the chest wall. That does have some implications for future transplant, but I can say that at most transplant centers now, they will consider folks that have had pneumothorax and pleurodesis or the putting in of these chemicals, at least consider them for lung transplant, and often they do get listed and transplanted. So I think that ends my little presentation, and we can go into some discussions.
A meaty presentation in
Thank
a short
you.
amount of time. I'm
It's a lot to cover there.
I wish I had a pencil here because I kept
No, it's
wanting
like,
to
what
jot
do I-
down questions that I want to follow up with. So, so much to talk about there. And so I think what we're going to do now, I'm going to switch chairs with Becca so she can be in front here, and Becca can share her experiences with some of those issues that Dr. Moss just spoke about. And then we can just open it up for discussion, and we have questions. People can ask questions of Becca and Dr. Moss. Also, just sharing your own experiences will be helpful. So right now, let's switch places. Thank you, Becca.
Hello, I am Becca. I am 31 and I have CF. I was diagnosed, excuse me, as you know, coughing is a common side effect or whatever you want to call it, a CF. I was diagnosed at 6 weeks old, but they thought I had CF when I was born. Dr. Moss did cover a lot that I've been through, so I think the way that I'm going to try and remember what he went over, and you guys can remind me, is I'm going to start up here, because that was one of the major things that he discussed that I have issues with constantly. So chronic sinusitis. I have sinus infections all the time. I have, as of last year, December, I've had 4 sinus surgeries. And they seem to help, you know, for the time being, but then with CF, the scar tissue grows back, which then clogs the openings of the sinuses, and I've currently had a lot of issues lately with that. I unfortunately got strep throat, which then led to a sinus infection and an ear infection, and that's a little bit abnormal for me. Usually it's unrelated to getting an illness like that. It's usually like more CF related. Every day I do sinus flushes twice a day. Sometimes they have steroids, sometimes they have antibiotics, sometimes they're just saline. And I remember when I first started having to do that, oh my God, I was such a baby about it. I did not want to do it. I hated it. I would, stay in the bathroom for an hour before I'd finally just commit to doing it. It's very uncomfortable at first, and then once you get used to the flushes, it helps a lot. And it just, just feels like it's opening stuff up. So that is definitely an issue I have all the time. I see my ENT regularly. I see the nurse practitioner at ENT regularly, which helps. I like to keep a close eye on it. So as far as hemoptysis, luckily I haven't really had to experience that much. I would say maybe once have I experienced it in the hospital, and like Dr. Moss said, it was very terrifying. And what they did was they stopped my vest for a day, and they stopped the hypertonic saline, which is a nebulized medication I do. It's very salty, and what it helps do is, cough up the secretions, so they kind of want to stop that for a while. Funny story about hemoptysis, even though it's not funny. One time I thought I had it. I was at home, I started freaking out, and I realized, I had some hot Cheetos today. So I was able to kind of calm down. But then when I actually had it in the hospital, it was pretty scary. And luckily it wasn't, it was just a tiny bit, but just a little bit. So I can't imagine for people that, have it regularly. And just because seeing blood is just not very comforting. A couple of the bacteria that Dr. Moss talked about, the two most prevalent ones are actually ones I have. So I have staph and Pseudomonas in my lungs at all times. I often get them in my sinuses as well. So I do IV antibiotics frequently, and unfortunately my list of IV or antibiotic allergies is insane. So every time I get admitted for a tune-up or lung exacerbation, it's kind of a challenge for all of the doctors to figure out, okay, what are we going to put her on? Is she going to have a reaction? In addition to doing IV antibiotics, I do nebulized antibiotics. So I switch, like he mentioned, you do a month on, a month off. And I used to do tobramycin, but that's one of my allergies. So now I'm currently doing Caistin, and I alternate it with Colistin. And I think it helps. I mean, it can't hurt. It kind of keeps the bacteria under control and tries to keep me to be prevented from needing IV antibiotics. What else have we talked about? I haven't, luckily my PFTs, the FEV1, like he discussed, is high enough to where transplantation has not been discussed at all. And he's discussed that it needs to be about 30 or below. My baseline, which is where you were at kind of like normally, was in the 70s until this past summer, where it dramatically dropped to 52, which was really hard for me to go through. I did 2 weeks of antibiotics and then had to, those actually lowered my PFT, so I had to do another 2 weeks. And luckily, we were discussing, this is your new baseline, like just kind of have to accept it. This is how CF works, Luckily, it came back up to the 60s, low 60s. So even though they're not in the 70s, I'm happy that they at least went up from the 50s. And I am grateful that they're in the 50s and they're not, lower. You just have to accept that that's just something that happens with CF, and they're slowly going to go down. You can't really prevent that from happening. You just have to, like Dr. Moss said, if you feel a sickness coming on or an exacerbation, you need to attack it right away. So I've been pretty good about that. Earlier in my life, I was not. I would wait to tell the doctors, and now I'm like, I'm not feeling too good. I think I need to come in for a tune-up. So yeah. I think that's what's helped a lot, is attacking it head on as soon as you feel it. So I think Sorry, that was pretty meaty too. I was trying to talk fast so I could remember everything that
That's
Dr.
great.
Moss had discussed.
Yeah, you never had a pneumothorax. So.
No, not that I'm aware of. Yeah,
That's
knock
good.
on wood.
Yeah.
Yeah.
Okay.
Yeah. So,
And I just coming back to the measurement with hemoptysis, because I think it is interesting because, as you said, it wasn't anything, it resolves itself, but I think for many people that I talk to, it is a cause of such anxiety, fear that it will happen, fear that it will recur if you've had it before.
That immediate anxiety, but also there are folks that have not a lot, but it keeps coming. And so what do you do with that? And that's a difficult situation because it's not life-threatening, but it is very distressing.
Right.
And it may pretend something more. So,
and that was my, that
so
is
sometimes
what I was
people have to
wondering.
delve into that territory. Well, what should we do in this particular situation? And that's a judgment call. That involves the patient and the caregivers and whoever else is invested in the well-being of that person to decide, should we just continue being conservative or should we get a little more aggressive?
Right.
Yeah.
And so is there some sort of measure of when you end up taking that step for embolization?
Well, I'm very personally conservative about embolization because it really does require tremendous expertise. The interventional radiologists have to pick out the right place to go, and it's a real tangle in there, and it can be very difficult, and there are cases where they don't get into the right area and don't fix the problem or actually create another complication.
Right.
So I think you have to be very careful about that, and in almost all cases, we don't do it unless it's really massive or life-threatening hemoptysis. In addition, there are some recent papers that suggest there are some medications now that may be useful in the treatment of hemoptysis that may preclude the need for embolization, but we still need more information about whether that outweighs the benefits of doing embolization if it's indicated.
And I don't know if anybody is on Zoom that wants to jump in and share their experiences about hemoptysis or any of the things that Becca talked about or the issues that Dr. Moss spoke about. Is anybody wanting to speak? Are you, Mary will be, yeah, if you can, there we go. Yes, we can.
Loud and
we
clear.
Can't see you, but we can hear you.
Okay, good. I know. So I have experienced hemoptysis quite a bit, especially over recent years. I think my first episode was probably either late 20s or early 30s, and I'm 41 now. So, and I've been hospitalized probably like 3 times in the last year or so for it.
Wow.
No fun. Very, very scary for sure.
Yeah. And, you know, I was curious because I see the measurement there. Was it 240 mLs is considered?
Yeah, which is
serious,
kind of a
which-
number out of a hat.
and I was
what does
doing
that
my
mean,
math
right?
going, okay, wait, there's 5 mLs to a teaspoon, 3 teaspoons is a tablespoon. I was trying to quickly do my math, but like, how much blood is that?
It's about 8 tablespoons. Yeah.
Is it about a cup?
8 tablespoons. It's about a cup. Yeah.
Wow.
So it's a lot
Wow.
but again, it's over 24 hours, so
Right.
it could be coming slowly.
But you know, when I'm talking to people to try who don't seem like they're getting how serious CF is, quite often I use hemoptysis as the example because I think for most people it is the most horrifying thought, and that's for people who don't have CF. And then I can only imagine. I mean, once it happens once, Mary, I'm sure you're waiting for the shoe to drop and for it to happen again.
Yes, definitely. You feel like, why did this happen? And so then anytime you get sick, you're wondering, is this going to be another episode? But frankly, it often comes out of the blue. You're feeling fine, you're going along, you cough hard, and you can feel something pop. But then you do feel like you're kind of drowning in your own blood. It can be pleasant for sure.
Right.
Yeah, again, I come back to emphasizing the importance of early and aggressive treatment of any lung disease because hemoptysis really follows the infection and inflammation. It's not going to occur without that process. And so if you can forestall those things, and we can do that now with the modulators as well as some of the older treatments, then it's less likely to happen. In your case, Mary, you got it and you have to deal with it. But as we look to younger patients, we hopefully will see less and less of this as a problem.
Right.
and I'm sorry you have to go through that, Mary. That's no fun on top of everything else with CF.
Right. But there's always something worse, right?
Yeah, that's how you gotta see it.
One way to look at it.
that whole
You
thing
have
about the known enemy versus the unknown
Yeah.
enemy.
It could always be worse. That's very true.
The other thing you mentioned, and this is unrelated to the hemoptysis, but still, with the smoking statistics were stunning to me. And this is from the registry that you're getting this?
Yes.
Which, to me, and I don't know, but I've spoken to so many people who a whole issue for adults is how much do you share with your physicians, especially if you have advancing lung disease and you're thinking, wow, I may need a transplant someday, and so I want to be a candidate and I don't want to have the black marks in my chart, so to speak. And of course, with the recent thing with all the vaping deaths and illness, and people are starting to think we need to check in more.
Yes.
But I was surprised the numbers were that high, and I actually thought that really scares me because I bet they're much higher because of fears of disclosing that to your caregivers. But I don't know. As a caregiver, what do you think?
I think it's probably an underreport because of that reason. So remember, most of this is secondhand exposure. So I'm assuming a lot of this is in the home where the patient is living. And that just emphasizes that CF, it takes a village to treat it, right? The family has to be involved, and this is one area where they can actually do something proactively to avoid an exposure that can make the problem worse. And it's true for vaping as well. We know less about vaping than tobacco smoke, but clearly now there's a lot of concern about that also. So yeah. And the other thing that comes up, and we actually had one of our fellows studying this question, was the use of marijuana, particularly in adolescents and young adults, who often will want something for pain control or anxiety. And if that's the case, then edibles are clearly going to be superior to using anything that you inhale to try and treat those problems. So I just throw that out there also.
Absolutely. And I hope, it's one of those issues where more and more states, certainly with medical marijuana, there are more and more states where it's legal, but even recreational.
Right.
And the hope is some real research can start being conducted, because for so long it seemed like it's out there, everybody's using it, but nobody's doing the research because it's not a legal substance. But it'll be interesting to see. I just spoke with somebody last week, an adult with CF, who confessed that he feels like one puff of marijuana is he actually
big help,
a huge help.
Right,
anxiety, depression, pain, sleep problems, and said and it's like I have this shame that I do it because I know, like any doctor, and he would be a person who is not disclosing for fear that it will make him seem like he's not adherent, whereas he's extremely adherent in other ways. So we won't ask if people want to share their stories, they can, but this has been recorded, so
we're in California where none of this is a problem.
Exactly. Does anybody else, if people have questions or comments, feel free. Brandon, are you keeping track of whether people? Teresa, talk to us. Hi, Teresa.
Hello. Can you hear me?
Yes,
very well.
We can. Welcome.
Hi. I'm a 53-year-old with homozygous delta S508, and I've just gone down with APA and impaired glucose tolerance. And I was interested in the possibility of whether it is possible to eradicate it. Obviously, I'm not the most usual expression of cystic fibrosis, being 53 and significantly overweight. So, is there a chance to eradicate aspergillus?
You happen to have asked a very difficult question, so thanks a lot. Some people will treat aspergillus if it's found in the cultures repeatedly and is associated with increasing symptoms, an exacerbation or decline after a period of stability in lung function. Many folks won't treat it unless those things are present. So in your case, it really depends on how it's affected you and whether or not it's had a clinical impact. And we still don't have good enough research to know a definitive answer to your question.
All right. Well, if I manage to eradicate it, obviously I'm quite unusual, and mainly due to a thyroid operation in my 20s. I'll get back to you and let you know if I manage to eradicate it. I do have I probably have the unproductive modifier because I am weirdly unproductive for a 53-year-old with CF, despite being homozygous delta F. So I'm hoping that with the combination of tight blood sugar control and, I mean, I am on itraconazole 400 milligrams a day.
Yeah, you mentioned
my lung function had gone down over a year before I punctured it. So
I think you mentioned
it's been suspected before I went down with it.
Teresa, did you say that you had been diagnosed with ABPA? Is that right?
Yeah.
And so were steroids tried?
Yeah, no, I'm on steroids.
Oh, you are? Okay.
Currently, I'm down to about 5 milligrams a day. So they decided to treat it quite aggressively, and I'm on 5 milligrams of steroids and the itraconazole.
Yeah, one of the problems is the treatment of ABPA with steroids in terms of the diabetic problem. So it's probably not helped that whole situation.
Yeah, it has made the good news is that being able to get away with doing a low carb diet, my blood sugars are almost entirely normal with just the occasional spike if I cock up and eat bread. So I'm just waiting for my continuous glucose monitoring results to come back to see whether that they're thinking of putting me on metformin rather than insulin because they think that that's appropriate in my condition. So yeah, interesting. If I manage to eradicate it, I'll let you know.
Okay, we got a deal. Hopefully it will work.
And one thing I could have said when I was doing my introduction, Dr. Moss is one of the most preeminent experts in the area of ABPA and aspergillus. So you are asking absolutely the right person. This is a great opportunity. Any other questions or comments from people?
There weren't any more questions, okay. But on Facebook, someone asked about the use of CBD oil. Mm-hmm. Like if anyone's using it, but.
So the question is whether people are using CBD oil for symptoms. Dr. Moss?
I have no doubt that a lot of people are using CBD oil because people are using CBD oil for everything. And will it work for any CF signs, symptoms, or problems? I just don't know. There's really nothing out there that I know of in the medical literature that really has a bearing on that. It's probably harmless, but I don't know if it's effective. And that's the best I could say about it.
And I would say anecdotally from many people that I've talked to who are using it, it really is more for sleep issues than anything. So that's what I'm hearing from the field. So I have a question for anybody who's listening, question for you, Becca, and it really comes from the issue of cough, because when we had the patient-focused drug development meeting, that was one of a key quality of life, daily bother, issue, challenge of having CF, and I can speak, not saying any tales out of school, but my daughter Tess has a chronic cough. I can find her anywhere. We can be in the biggest, department store, and I'll go, oh, she's over in shoes, because I can hear her coughing. And through the years, it's been a sort. It obviously disrupts her sleep. Mm-hmm. Even when she thinks she slept the whole night, I know she's not sleeping well because I can hear her coughing. Also, it's the shame is not quite the word, but it's just this chronic embarrassment because people are always treating you like you're sick and a little like, whoa, what are you doing in the bus when you've got that horrible cough? Or people say, oh, that's a terrible cough. Can I offer you water? Yeah. So I'm just curious if other people have experienced that. It's the part physical aspect of CF, but also the emotional aspect impact of it.
It's definitely a big issue in my life. I used to be very embarrassed about it, and now I don't know if it's as I've gotten older and have gotten more comfortable with my CF, but I've just gotten to a point where, well, I know I'm coughing and you can look at me, but you can keep looking. Like, I almost want people to say, like, why are you coughing? And then I can explain, like, rather than look at me like I'm contagious, just ask. But I know people don't feel comfortable doing that.
I have a question.
Yeah.
What amongst the treatments that you've had has helped your cough?
I would say, on a day-to-day, just a normal day basis, I do the vest, and I have to do it 3 times a day. and that has helped, I think, the most.
So the clearance is the most
Yeah, the
important
clearance.
thing.
But it's also doing the nebulized medication with it. Because I can do the vest without the nebulizer, and I can do the nebulizer without the vest.
Right.
And it does provide some relief, but they do go hand in hand. And I do need both of those 3 times a day. It's very rare that I go only doing it twice a day.
And do you find the sinus flushes help? Like I know for Tess, she has a lot of sinus disease,
Yeah.
so it's a chronic, drip.
Yeah, I mean, I haven't really experienced the postnasal drip until recently. I don't think it's ever really been a huge issue until recently. And I don't know if that's because I was getting sick on top of it, but just like the thick postnasal. Yeah, I know that's lovely guys, right? It got really bad to where I couldn't even breathe. Like I had to breathe through my mouth. I couldn't breathe through my nose. The sinus flushes do help that. But I feel like the thing that causes the most immediate relief is the vest and the nebulized medications. I do the airway clearance for 30 minutes at a time, and I would say within 10 minutes of doing it, I already feel better. So, yeah, I used to get embarrassed, and now, it's just part of CF.
Do you take a modulator?
I don't believe so. What is that?
Like Kalydeco? Or?
Oh, sorry. I do Symdeko.
You do Symdeko.
Yeah.
So when you started that, did you notice a change in your cough?
I don't think so. So the way I look at it is I was hospitalized a lot after that with exacerbations. The way I look at it is I think I could be worse without it. I know that it's probably helping me, but I haven't really experienced like
a dramatic change.
Yeah, dramatic change.
Okay.
I am looking forward to doing Trikafta.
Which is a lot like trifecta, right?
Yeah, right. I was like, I did try the Orkambi and I did not get along, and I gave it 10 days, and then I switched to Symdeko. So I don't think it's harming me. I just don't know if it's providing like dramatic relief, and that could be me being negative about it. I don't know. But I still take it.
One thing that we found there as 3 modulators now on the market, and now Trikafta is about to appear, has been that both Orkambi and Symdeko are less effective than Kalydeco in people for whom that's prescribed with gating mutations, and the effect on cough is probably less noticeable with those 2 drugs. When you switch, which I assume you're going to Trikafta, you're going to find that it may have a much greater impact on your cough than what you've been taking so far, which is another hopeful thing about it.
And Kalydeco, I believe I can't take it because it's based on your mutation, correct?
It's based on your mutations, yeah.
Okay.
Yeah.
And it's so funny, you say you've just gotten used to it, and you just like, if you want to stare. For Tess, it depends on how rude the person is.
Oh, yeah.
If
Oh,
they're
yeah.
really
It's
rude,
definitely...
she'll just look at them and she'll say, I have a fatal lung disease.
Oh, yeah. I mean, I'll give people
That will
looks.
generally shut them up, right?
Yeah, I'll give people
But
looks.
it depends only if they're rude.
Yeah. And it definitely depends on the situation. Like when I was in school, that was embarrassing because it's completely quiet and all I can focus on is not coughing. And the more you hold it in, the more you have to cough.
Right.
So I think now that I'm out of school, and I'm like, right now for work, I don't really deal with people, so that helps because I know when I worked at Starbucks, I was constantly self-conscious. I'm making people's drinks. They're probably thinking I'm sick, just coughing in germs into their coffee. So it definitely depends on the situation.
And the cough, too, the other part of it beyond that, and especially for women, is that it's so linked to that intense cough to stress urinary incontinence. So it leads to like a whole, it's like the classic CF thing. Everything leads to another thing.
Oh, yeah.
So addressing, I mean, I thought that was interesting from the hearing, just people, if they could have something that could control the cough, that would really actually change their quality of life significantly.
Well, and it's exhausting.
Yeah.
It makes your body sore. It's like I fractured my ribs a couple years ago, and I'm still having issues with it because of the cough. Like every time I get sick, I cough more, and it's just a constant. It affects a lot of things. Even if you're used to your cough and comfortable with it, it affects a lot of other things. So
Tess has displaced her ribs.
I think one of the unfortunate things about it, especially at a certain age, I'm thinking young teens in particular, where they're really focused on the peer group, right? And they may not have told people in class that what they've got, and they'll try to suppress that cough. But if you think about the fact that CF is a disease that where your normal mucociliary clearance is not there, you're relying solely on cough. If you don't do it,
it's not good.
That's not good. And so I think being open and honest about it it's usually helpful if you can bring yourself to that point of saying, I've had this problem where I cough, and you just have to accept that this is it, and I'll try not to be disruptive, and whatever it is, but don't suppress the cough.
Well, it took me till I would say early to mid-20s to be comfortable with my CF. So I know as a teenager it was hard.
It's got to be hard.
Yeah. And I think, like I said earlier, as you get older, it's just kind of, okay, this is me. You know, if you are not comfortable with this, then, I'm sorry, but it's nothing I can help. So it does help with age. As you're younger, you're more self-conscious of everything, let alone something that not everyone has.
Right.
So.
Right. Anybody out there have cough stories, comments, or any comments? Share your stories.
Hey, it's Mary again.
Hey, Mary. Welcome back.
I was just going to say that going on Symdeko really changed my cough for the better. It's not anything like it used to be. It improved a little bit on Kalydeco, but I still had exacerbations, and then I switched over to Symdeko, and it's been, dried it up, got rid of it mostly. It's been awesome.
Wow.
Good.
That's great.
Yeah.
Nice to know that you're a good responder.
Yeah.
Yeah. And then
And it changed my sinuses, too.
Oh.
Wow.
Yeah, that's another interesting point. There has been,
infection.
Some people have studied that and seen an effect on sinusitis.
Good.
Yeah.
Pretty amazing. So will you then be on
I was just
Trikafta?
going to ask that.
I know. I think I eventually will get there onto that. So.
When did you start this Symdeko?
I started in the spring, so spring of 2019.
Okay,
So I've
so
been
pretty
on
recent.
Symdeko for probably about a year.
Okay.
And like I said, noticed some improvement, but still continued to get sick. But when I was better, I definitely felt better. But then I switched over, I want to say, I still had, 3 hospitalizations for hemoptysis, so then that got kind of the ball rolling to switch to Symdeko. And so that, I want to say, happened in the spring. And, it was to the point where I went to clinic and I was like, there's something wrong with me. There's something wrong with my nose. It's so dry. I don't know what's wrong. I don't have secretions. And they're like, yes, that is the point.
That's a normal
Like,
nose.
I'm not used to this.
I was like, oh, okay. Alrighty then.
Good story.
Yeah, no kidding. Well, if your sinuses are better, I'm sure.
Yeah, because then it drains.
Yeah. Yes, so good.
Yeah.
That's another thing with the sinuses is you have to attack them early on, because if not, then they're going to slowly drain to the lungs and cause that. So
When was your last sinus surgery?
Right.
December of last year. So about a year ago.
About
almost.
a year.
Yeah. And they said there's already scar tissue
Starting
in
to,
Mhm.
close
So-
down. Yeah.
Polyps, do you have
there.
recurrent
Not that I'm
polyps?
aware of, no. It just seems like there's mainly scar tissue.
Got it.
So,
Yeah, that's test.
Yeah.
She said 4 or 5, I think.
yeah.
It's been
And they've
horrible.
gotten a lot easier, which is nice. The first sinus surgery I had, I was middle school. So, what is that? 16? I don't know how. I can't do math right now, but it was a long time ago. And the recovery from that was awful, and there was things that they had to pull out. And now it's, last sinus surgery, they didn't even have to put like drainage tubes or anything. So they've gotten a lot easier, a lot less painful. And it's also a thing that once you do it, like, you know what to expect, which always helps nerves.
I want to make just one little editorial comment, which is, like a lot of other things about CF, it really helps to work with a ENT doc who knows about CF, because a lot of them really don't see much CF, and their approach could be quite different.
Yeah.
And the docs that do, and it's like diabetes, the docs that know about CF can usually treat it much more effectively.
Yeah.
Because there are very particular issues that make CF sinus disease different from non-CF sinus disease, just like CF diabetes is different from other types of diabetes. Yeah.
Are there any questions? Otherwise, I'm going to jump in. Comments or questions? Teresa, come back, Teresa.
Hello.
Hello.
Can you hear me?
Yes, we can.
Yes.
Hiya. I'm in England, so I haven't had the chance to access any of these drugs, but it's just
yes.
the agreement has just been reached
Yes.
for the first two. And I was just wondering, I mean, I never expected to get access to them because I've got a 90% lung function. I was wondering if there's been any findings on the effectiveness of these drugs in helping to reduce CF-related arthritis, because that's a very severe problem for me.
Not that I'm aware of, but as I mentioned before, people have looked at non-lung pieces of CF on these modulators, mostly with Kalydeco and folks with gating mutations, and the effects are seen throughout the body. So it wouldn't surprise me if there is a beneficial effect on the arthritis associated with CF. But there's no studies that I'm aware of that actually look at that in depth. But I think the odds are that it would be helpful.
Yeah, it's going to be interesting at the very least.
Yes.
Absolutely. And it's so interesting because Kalydeco, it's what, 7 years since it's been available?
2012, yeah, 7 years.
So it seems like they're starting to build up the information, right? They're starting
especially
to be
on some of these other non-lung complications
Uh-huh.
like diabetes, sinus disease, GI function. We now know GI function is improved. So it makes sense. The drugs are systemic. You're taking them by mouth. They affect every tissue in the body. Wherever CFTR is there and not working, it at least has a shot to make that better. And in general, the earlier you do it, the better it's going to be. Yeah. So all those things I think apply.
And how do you get people to start grabbing onto this? Like I think of CFRD, and right now I'm not thinking of her name, but it'll come to me, who's preeminent. She's at National Jewish in Denver. Antoinette Moran, isn't that her name? I heard she's starting to try and collect information about CFRD and the use of modulators. And
Yeah.
I can tell you, Tess has been injecting insulin since she's 11. And since she has been on Symdeco, I actually have teased everybody.
I know, I say it both
well,
ways.
It's so funny because
who knows?
Yeah. Well, and when
Yeah.
the whole launch in Boston, Tess actually went and performed at this, and it was Symdeco. But then everybody says Symdeco,
Yeah.
so I joked, like, whatever name you choose the next time, like, make it that it's just clear.
It's based on my mood, how I
So,
want to say it.
when she started Symdeco, she started to have crashing lows. And she was having a constant monitor, and during the night she was crashing. So first it was, well, stop doing the Lantus, because that's your baseline maybe is now too low. And then it was, stop doing the Humalog. Like, she would inject exactly what she would do for the same meal and have crashing lows. And so now literally she just is supposed to inject for corrections. So, but that's all anecdotal, right? I mean, she's the N of
But
one
there are more
in
and more
that,
of these accumulating, and more studies are being done, more structured studies to look at it. And it's interesting, in the animal models of CF, they can definitely show that CFTR is involved in insulin production, and these modulators do have an effect on that that's beneficial. So I expect we'll get more and more solid information about the positive effects on diabetes.
So that, actually, what you just said, because I was wondering, what would the reason be? Is it that there is more insulin produced, or is that there's the ability for the insulin? What is happening there? All of a sudden, she's getting insulin.
I'm not an expert in that area, but Dr. Moran could probably answer that better than anyone. But I do think there's some information that insulin production is probably improved. Whether insulin resistance is lessened, because both of those things are happening in CF, but it's primarily a problem of insulin production. And the modulators, like Kalydeco and gating patients, may improve insulin production. So that's a real hopeful sign also. Again, I think as diabetes goes along, more of the pancreas is destroyed, so it's important to try and treat it early.
And Teresa, we want to know about that as well.
Yeah, I think Teresa mentioned going maybe
really
on metformin. Is that right? So that's
absolutely.
That's another idea that people are tossing around. Although the conventional wisdom these days is still to use insulin, because that's the missing element.
Yeah.
But
But
good luck to you with the metformin.
Yeah, well, it'll be interesting now, too,
Yeah.
if she starts the CFTR modulator. What
Right.
happens there? Maybe she won't even need it. So.
Yeah, my BMI is 33, so I think they're working on the basis that I'm the second patient they've considered using metformin on, because obviously with a standard presentation of CF, that's not advisable. But yeah, so I'm going to be a bit of an experiment.
Well, good luck as a guinea pig.
Hey, been doing it all my life.
That's CF.
Exactly. Thank you.
Sure.
And we're getting close to the 1 hour mark, but I did want to just ask, coming back to the whole spreadsheet you had of the pathogens and the Pseudomonas rates going down.
Yes.
And is it, the rates are lower for children, but are the rates, I mean, is there more eradication happening in adults as well? I mean, I always think for years, of course, for older people, like the 80% statistic always sticks in my mind. 80% of adults are colonized with Pseudomonas, and is that number changing as well, or the percentage is changing really because of the pediatric population?
I think it's driven mainly by the change in the pediatric population. If you arrive at your adult clinic or your transition and you've got chronic Pseudomonas, it's unlikely to be eradicated. There are adults that have onset of Pseudomonas that have either had it eradicated before or never had it. So that does occur, but it's much less common at that age, because usually it's quite early that Pseudomonas comes into play, usually preschool years. So the eradications, as I mentioned, are often successful, but you go through several rounds of them and eventually the bug sticks. And that's that 50% or so where it's present. And in adults it's higher. It's probably closer to 70% of the adults.
Is that the same with staph? That's what I was wondering. Like, I will always have the staph and the Pseudomonas, correct? Or is it based person to person?
Staph can be eradicated.
Okay.
And in fact, in some countries like the UK, Teresa is one of our UK folks. In the UK, they take a different tack about treating staph. They often give it prophylactic anti-staph meds to young children to try and prevent staph. That's controversial. We don't do that in the States. People argue about that a lot. But if you do have staph and it's felt to be contributing to an exacerbation, then you will get an anti-staph, either oral or IV drug, and that will usually eradicate it, because staph is not as tough as Pseudomonas to get rid of. MRSA is a little bit different because eradicating that is quite difficult, because it tends to be in different body surfaces, right? So that becomes more complicated. Yeah.
And can we talk about Cepacia briefly before we end? I'm just curious. I mean, everybody hears that. It's like the C word. It's the thing that everybody is most terrified of. Well, there are lots of things to be terrified of. But of the pathogens, Cepacia just strikes terror, because obviously transplant potential.
Luckily, it's still pretty rare. We haven't seen it. West of the Rockies, it's the rest of the Sierra Nevada, it's very rare. In some places in the country, in the Midwest in particular, much more common. But having Cepacia, it's a little complicated because there are many different kinds of Burkholderia, and the Cepacia syndrome, the thing that we really fear, is really based on just certain strains. So you can definitely have Cepacia in a less virulent strain that you can get along with and not deteriorate rapidly. But I think the place that it really still plays a major role is the transplant situation, and the fact that many centers still don't want to transplant folks that have Cepacia. So if it can't be eradicated, then that shrinks the places where somebody can go and get listed. That's probably the major impact. Cepacia syndrome still occurs, but it's pretty rare.
And what is used to try to eradicate it? And is it
good question. It's not often successful. Usually multiple different antibiotics, 2, 3, 4 antibiotics combined to try and get rid of it. There was a attempt to use Caistin in a study, which didn't do it. So we don't have a good inhaled antibiotic that can get rid of Cepacia. So it's one of those situations where first you have to decide if you have it chronically, whether or not it's one of the more troublesome strains or not. And if it's associated with a rapid decline, then being very aggressive which means multiple antibiotics for long IV courses usually.
Guess we'll stay here west of the
Yeah.
Sierras.
Stay west.
Stay west. So are there any other questions or comments from the people online? Now's your chance to jump in before we wind up. All right. This is the quietest group ever.
Is it something I said?
So we're out of time now, but I'm so grateful to everybody who joined us. Teresa, we want follow-ups. So thank you, everybody who participated.
I do see one chat question that's come up.
Do you have a question? Oh, yes.
Mary is asking, can you put that up again? Does MAC, something about MAC?
Oh.
Mary, go ahead.
Go.
So, I just have a question. Does culturing MAC keep someone from getting a transplant?
MAC can be treated successfully. So usually, if you're in that territory of heading toward a transplant, your caregivers would try to eradicate it through a regime of several different antibiotics. I don't think that MAC per se is a contraindication to being listed, but that could be a problem at certain transplant centers. Again, transplant centers they're very individual in their criteria. As folks who have either been transplanted or are looking at that know, sometimes you have to shop around and really try and match your particular case to the criteria of a particular transplant center. But I don't think MAC is one of the most intractable problems that can be solved.
Okay.
Okay, we were going to go, but now that triggered another question.
Did it?
Which, when you say it, well, for me,
Oh,
just
for
about
you.
the shopping around for centers. I mean,
Yeah.
in this day and age of the multiple insurance complications and knowing the expense of transplant, is that something that people, I mean, is it plan dependent, but you literally could appear at another transplant center and ask to be considered? Do you have to go there earlier and become a patient there for a while? Is there... What is the...
Well, I think it's complicated. You can try it yourself. Usually it helps a lot to have your CF doc or group refer you and be behind that. And I just know many cases where people who got transplants had been evaluated at more than one center before that occurred. And usually it's because of different criteria at these different centers, and some are more aggressive than others in terms of the things they're willing to try and do and the depth of experience they have. So nowadays there's a real push to try and standardize the approach to transplant more and more, but I don't think it's there yet, but efforts are being made to do that for sure. And it's important because this is very traumatic as well as extraordinarily expensive. To get evaluated at place A, get rejected, and then have to go to place B, which might be across the country.
Right.
Such an incredible stress on the patient and the family. It's almost incomprehensible. But people do it, and sometimes it works.
Right.
Yeah.
Right. Well, with that, we're going to wind this up, and I want to thank everybody who participated, everybody who watched, and I really want to thank Dr. Moss and Becca for being here and sharing your
Thank you.
knowledge, expertise, wisdom, and insights. And again, I want to thank Vertex, Gilead Sciences, and Chiesi USA for their sponsorship of the podcasts. And our next one will again repeat this town hall format, and our next topic will be addressing mental health issues. So we will be promoting that, and
Speaking
we
of
hope
stress,
you will join
huh?
us. Speaking of stress, that's right. So thank you all, and good night.
Thank you.